Right. So thank you very much for what I think is a rather dubious honor to give a lecture on radiotherapy in 15 minutes. I think it's like asking one of you neurosurgeons to talk about neurosurgery in 15 minutes. But anyway, and I'm sorry I can't be sitting with you and drink Retsina rather than sitting at home in London, which you're probably in some warm setting in Greece. Now, this is the title of my talk, and what the neurosurgeons should know. And if you happen to go to sleep in my talk, this is the punchline, and I trust you all are using it. Now, as you know, radiation is a very important treatment in the management of brain tumors, alongside all the other treatments. And there are certain perceptions about it, about neurosurgeons. Certainly, I've seen those in my career, that surgery is considered very safe and effective and curative treatment for brain tumors, and radiotherapy is considered a very toxic treatment, and it's only a palliative treatment. And I think, like there is a side effect profile to surgery, you don't say to everybody you're going to be cured and there's going to be no toxicity. You say there is a certain probability of side effects. The same about radiation. And there is a probability of side effects, and there is a need for a balance between the effectiveness and side effects. And the side effect profile is actually relatively low. And some of the side effects that are being talked about, like necrosis, actually the probability and properly carried out radiotherapy is very low. So it is an effective treatment. Perhaps one of the reasons why radiotherapy is not considered to be as effective is because our perception of different endpoints. Now, the surgical endpoint in terms of achieving success is removal of the tumor, and therefore it's no longer visible. I would challenge the neurosurgeons that are listening. Perhaps they don't completely like to remove this kind of a tumor, but in radiotherapy, the principal endpoint is tumor control or absence of progression. And I think in the long term, it is the appropriate endpoint, because it's the primary endpoint is survival without neurological deficit or with good quality of life. So arrest of progression is as important, if as complete removal. So you need to kind of switch the thinking about this. Now, you, as neurosurgeons, you're bombarded with lots of names, and I've just mentioned some of them here, and they're all a bit baffling, and you probably don't know what they are. And of course, if they have some name in it that you recognize, like stereotactic or radiosurgery or knife, you believe that they are they are actually close to radiosurgery and therefore effective treatments. But actually, there are three aspects of radiotherapy, and I think those are just technical terms. I mean, what really matters is three things. It's about delivering radiation with precision to the site of the tumor, which I call conformality, conforming to the shape of the tumor, and giving it with precision means delivering it each time exactly to the right place. And another issue is the fractionation, and the last is, and possibly the least, is delivery equipment. And I think probably in neurosurgeons' eyes, the delivery equipment is the primary of primary interest, but actually is the first two that are most important. Now, what does it mean? Well, first of all, it's like in surgery, if you operate on the right thing, the results are fine. And therefore, if you irradiate, you have to irradiate the right spot. So in the example of meningioma here, you need to recognize exactly where the tumor is, and we need to outline it correctly. So if you were to miss some of the tumor here, the results would be bad. Or if you don't treat the cellular portion, the results would be different. So localization is absolutely critical. And there's another example here: somebody with a large solitary brain metastasis in the cerebellum. And you can draw lines like this on the left-hand side, where there is some gap between the visible tumor and the outline that you're going to treat. And here on the right-hand side, it's very likely there will be some microscopic disease overlying this line, and it's likely that this would result in worse outcome compared to this. So you can see that defining the exact position of the tumor and exact site of the tumor is absolutely critical to the success of the treatment. Now, I don't know if any of you have seen a modern delivery machine, but the workhorse of radiotherapy and the one that can produce most of these, most of the high precision conformal treatment is a linear accelerator. And the radiation comes out of here. It's shaped, and I'll show you how it's shaped in this part of it. So the radiation goes this way. Sorry, it's jump back. And you will notice that there are other bits that are attached to it. And I just want to tell you that this equipment is what's called cone beam CT scan, where the radiation, this is an imager, and this is the source of X-rays, and we can actually take a CT scan close to the treatment. So as close as you can get to the process of giving treatment. Obviously, in neurosurgery, you see it directly, and this is an indirect way of checking that you're doing the right thing. So we have very precise way of knowing where we are. And although this machine is very heavy on metal, it's an enormous piece of equipment. The precision of it, in terms of the accuracy, is sub-millimeter. It's a very sophisticated piece of equipment. And as I said, there is some shaping device in the head of the machine, which is here, and it's really looking straight into it. And it's called a multi-leaf collimator, and you can shape the collimator so you can actually treat the precise outline of the tumor. And obviously this can move while you're moving the machine and so on. So it's a very sophisticated piece of equipment. So this is about accurate tumor localization. And the next thing is about precise tumor targeting. And you need two things. You need you need to make sure that the patient is in the same position. That needs immobilization. And second is image guidance. So there are different means of immobilization, either frame or frameless, like in neurosurgery. And you can see there are some detectors here, and you can monitor them during treatment, and you can monitor during treatment actually the bony structure. So that's called image guidance, and you can do image guidance with the linear accelerator with the CT scanner here that I've shown you. So you can do 3 to sub-millimeter accuracy. The next issue is fractionation, and there are essentially 3 ways of giving radiation. You can give them in single fraction, which I think you all recognize as radiosurgery, but it's single fraction radiotherapy. You can do standard fractionation, which is daily treatment of anywhere between 4 and 6 weeks. And you can give hypofractionated radiotherapy, means giving larger fractions over a shorter period of time. And I'll talk about these in a bit more detail in a minute. Now, the last thing is about delivery equipment. Now, they're essentially high energy X-ray machines, most of them linear accelerated. I've shown you. If you miniaturize the linear accelerator and put it on a robotic arm, it's called CyberKnife. It has some advantages, has some disadvantages, because it produces very small beams, and therefore the treatment takes much longer. You can have helical rotating linear accelerator that's called tomotherapy, very similar treatment you deliver. And you can have a multi-headed cobalt unit, where cobalt is actually what I would say an old-fashioned way of delivering radiation, because it's lower energy. But obviously, it's an effective treatment machine. But each of these equipments is capable of giving different techniques, either in terms of fractionation, in terms of shaping of the beam, and so on. But they're all very similar, other than if you use real non-relocatable devices, you can only give single fractions like the gamma knife. You can give only few treatments if you use CyberKnife, because of the duration of each treatment. So there are some restrictions in these in terms of fractionation. And this is what you get with the different techniques. And I don't want to go over this detail, but if you look statistically about the dose fall-off from the target, actually there are no significant or clinically relevant differences in the size of this blue area around the target. And there is a difference that's not shown here. It's about the homogeneity within the dose distribution within each. But there are no real statistical differences or clinically relevant differences between these techniques. And obviously, this is an example of a vestibular schwannoma. So lots is said about the machines, but actually the differences are very small. Now, lastly, I want to mention the word stereotaxi that it's really been borrowed from neurosurgery. And while you still use stereotactic techniques in neurosurgery, really, we use ordinary imaging without the need of the three-dimensional space. And so stereotactic radiotherapy really is a marketing terminology, because all of it is simply using all these three requirements, and they are just high precision localized radiotherapy techniques. And the stereotaxi we had used at the beginning, but we don't use it at the moment. So those are the three things that are necessary. Conformality and precision of radiation delivery is the perhaps most important, and requires the outlining and co-registrations. For example, you need very good co-registration between CT and MRI, which is open to human error, open to technical error. You need very good relocation accuracy, either with the frame or frameless technique. And you need some image guidance. And of course, you need to interpret those imaging appropriately. And the bottom line of this is that you need very good infrastructure in terms of the technical capability of the equipment and constant checking. And you need the clinical expertise. So not only technical, but also the clinical expertise at outlining the correct treatment to correct area to treat the tumor correctly. So my bottom line is that the clinical and technical expertise is actually more important than the technology that you use. Now, let me just, you asked me to talk about radiotherapy protocols, and I want to mention them very briefly in terms of dose fractionation and extent of irradiation. Now, the conventional fractionated radiotherapy, daily fractionation, is appropriate for most glial tumors, malignant and the low-grade ones, in very large benign tumors that sit too close to critical structures. Single fraction radiotherapy is appropriate for small benign tumors, away from critical structures, and for brain metastases. Hypofractionated radiotherapy is used. Sometimes it's because you want to save time, sometimes because it's a restriction of the machinery use. And I'm afraid there are very few randomized trials comparing this to either of the two techniques to know that it's equally effective. And it's crept in, and it's not unreasonable. It's crept in as a treatment, but I don't think it's been appropriately tested in randomized trials. But these are the ways of doing it. So firstly, about fractionation. Second, about the extent of irradiation. Obviously, you would like to irradiate as small area as possible, but you can't get away from very wide field irradiation, which is craniospinal axis radiotherapy, nowadays only used in medulloblastoma, and it's absolutely critical. We know that without it, there is a very high risk of dissemination and some already disseminated tumors. It's no longer necessary as a prophylactic treatment, for example, in ependymoma. Whole brain radiotherapy is being used less frequently, certainly in multiple brain metastases, as we can treat localized tumors individually. But you can treat localized treatment with some margin, and this is an example of high-grade glioma where we either can't see the edge of the tumor appropriately, correctly, or there is microscopic disease outside. And the very highly localized radiotherapy, which you probably call stereotactic radiotherapy radiosurgery, is for very highly localized benign tumors. So those are the, very briefly about the protocols in terms of dose fractionation and extent of irradiation. But actually, what is most important is clinical and departmental expertise. So I want to finish with the message that it doesn't matter what technology you use, what machine you have. What is most important is the clinical and technical expertise, and that's more important than any of the machines. And this is the take-home message. So thank you very much for your attention.